sorry, he's a professor there. So thank you, sir. When we requested him to take a few sessions, Amit, he readily agreed, and with this, on even Sunday, he's ready to teach us shock today. So welcome to you, sir.
Yeah, thank you very much.
We also joined by Dr. Nishant. Welcome to Nishant and all other members. So, and Shravan, I request you to start the YouTube live. Shravan.
Yeah.
Yes, sir. Yes, sir. Yes, sir.
Yeah. May I know if all of you can hear me and you can see my screen?
Yes, sir. We can see.
You can. Okay. Good evening. I've been asked to talk about shock. You know, in the next 35-40 minutes, I hope to give you some basic ideas about shock. Shock is a clinical condition that all of us doctors face on a fairly regular basis, and to have some basic knowledge about the pathophysiology and the practical steps that one should take once you see a patient with shock is something that all doctors must possess before they reach the emergency department as interns. There is no doubt that all of us must know about it. So I plan to start with a definition, have a classification of shock, some basic ideas about how you diagnose it. And being a surgeon myself, I'm afraid I will have a definite surgical bias. You know, I can't say I can talk to you a lot about medical conditions, but we will focus on the two common surgical types. And of course, as always, I think that my discussion and teaching will be on practical aspects, not completely focused on writing and passing exams. By and large, I talk about practical aspects, and so we need to focus on that. Just give me half a second, please. I'm sorry, this is one of the downsides of working from home. We had our home help trying to clean the place around me. So I had to say no, thank you. All right. Sorry about that interruption. All right. You know, if you look at the purpose for any function in the body, here we are talking about the circulation in our body. You know, shock is a situation where there is lack of proper circulation. And the purpose of circulation in the body, in very simple terms, is to have tissue oxygenation. We want cells in the body to live. Is there a problem with the audio? Because I hear some noise in the background. Okay, so no, I still have the disturbance. Can we have people muting their microphones? Can we see? Hello? Yeah, seems to be a bit better. Yeah. So the ultimate purpose of circulation is to make sure that the cells have enough oxygen to carry out their metabolic functions. So if you look at a classic definition of shock, it is a situation where there is tissue hypoxia, either due to reduced oxygen delivery, increased oxygen consumption, or inadequate oxygen utilization. Yeah. So I think people have to mute their mics, please, again. I'm sorry. Yeah. So as I was saying, we have a situation where we define shock as a situation where there is reduced oxygen delivery, reduced tissue oxygen delivery or utilization, which is tissue hypoxia, due to reduced delivery, increased consumption, or inadequate oxygen utilization. This is not what we normally think of shock. We always think about hypotension in shock. But if you look at the last of these, okay, either increased oxygen consumption or inadequate oxygen utilization, you can have a shock state either in the hypertensive state, hyperdynamic circulation, normotensive, or hypotensive. So in a classical theoretical sense, you can have shock even in a patient with a normal blood pressure or even a high blood pressure. But remember that shock is a situation of tissue hypoxia, and it will eventually lead to irreversible organ dysfunction. That happens if it is untreated. So the goal of any person treating shock is to try and reverse the tissue hypoxia so that we do not let organ dysfunction reach the irreversible state. A more conventional definition of shock is a situation where there is hypotension, there is oliguria, there isn't enough circulation to the kidney, so there is a reduction in urine output, and there is poor peripheral perfusion, classically shown by poor capillary fill. Okay, these are the three standard situations. And when you're talking about hypotension, even though we normally recognize the systolic blood pressure, as the marker for hypotension, mean arterial pressure is a more appropriate measure to have. The mean arterial pressure, as it is defined here, is given by this formula: twice the diastolic pressure plus the systolic blood pressure divided by 3. One needn't mug up this formula because most monitors that we use in our ICUs and in our operation theaters give you this by calculation by default. So to have a mean arterial pressure, MAP, of more than 60 millimeters of mercury is the usual target that one has when one undertakes resuscitation. All right. So, Pavan, can you explain this slide, please? What am I trying to say here?
Types of shocks. Hypovolemic is when the volume of the blood is lesser, so the perfusion will be decreased.
Yes.
And we can have shock, sir. Cardiogenic is defect in heart, sir, in pumping the blood.
Yeah.
So when there's a weak inotropic effect, then will have hypoxia and shock, sir.
Right.
Then obstructive is when something is obstructing, sir. So if blood is not going through the blood vessel properly, then also we'll have shock, sir.
All right.
Distributive is distribution is not going well.
All right. Can you give me 1 or 2 examples for each?
So hypovolemic is like hemorrhage, sir.
Yes.
Then cardiac failure, sir, for cardiogenic.
No, one more example for hypovolemic.
Blood loss.
Blood loss is one. Any more?
Road traffic accidents.
No, that is in blood loss in an RTA. But is there anything else where you can have hypovolemia other than blood loss?
Not sure, sir.
Gross vomiting and diarrhea.
Yes.
Gross plasma loss in burns. There's no blood loss as such, but you can have a large plasma loss in burns, for example. High degree, large surface area of burns. Cardiogenic.
Then this one is congestive cardiac failure.
Yeah.
Then any
causes for cardiogenic. We'll look at the spectrum later, but what are the causes for cardiogenic shock?
Sir, myocardial infarction.
Yes.
Myocardial ischemia. Then
that is
any
infarction.
yes, sir.
That is infarction.
Death of cells, sir.
Yeah. Only death.
Necrosis.
Can there be without necrosis? Can there be some other thing that affects it adversely?
Blood supply is less, so
myocarditis, even a viral myocarditis without actual death, but it can lead to pump failure. Okay, severe myocarditis of various cardiac toxic drugs. A lot of them can give you cardiogenic shock without tissue death. Obstructive.
When any mass is compressing on blood vessels.
What is the commonest cause? Is it mass compressing blood vessels? Commonest cause?
Like thrombosis.
Cardiac tamponade, man.
Yes.
So if you have a tamponade, or if you have an aortic dissection, where there is a lot of blood in the wall of the blood vessels, then there is no channel for the blood to flow through in the aorta. Okay, so cardiac tamponade, aortic dissection are common examples. Distributive shock.
Distributive is like blood vessel blockade, like thrombosis.
Think again.
Something.
What it essentially? What do you understand? Just by the name, what do you understand by it?
Distribution.
distribution, which means that the blood volume, total volume is generally okay, but it is not distributed in the right places for various reasons. So what are the things that can do that?
Head injury, it may cause like neurogenic shock.
Neurogenic, yeah, neurogenic head injury, you're right. More than head injury, what is more common? Spinal injury.
Spinal
Because
injury,
of the autonomic blockade, okay? The
Yes.
autonomic regulation of the circulation is lost. It can happen in head injury, but it's more often in spinal injury. But the commonest cause for third space loss, I'm going to talk a little more about third space later, but third space loss, which is a distribution, what is the commonest cause that a surgeon sees? Sepsis, okay?
Sepsis.
Surgical sepsis is the commonest cause. And so I'm going to today talk mostly about hypovolemic and distributive shock as exemplified by sepsis, because that is the ones that we as surgeons and many doctors, in fact, even in other disciplines, see most often. And as I stressed in the previous slide, lack of oxygen for cellular metabolism is the underlying pathological phenomenon. So I'm showing the same thing in a different way here. So essentially, you have in a distributed shock, the pump is okay, the structure, the volume of the blood is okay, but there is a maldistribution. In hypovolemic shock, the pump is okay, circulation per se may be okay, but there's no volume, there's no blood volume. Cardiogenic shock, as you can see, the pump is distorted. The pump is not right, so it's a pump failure. Circulation itself may be generally okay, volume may be okay. In an obstructive shock, the pump is bigger than everything else. The pump is okay, but it is trying to work against a huge resistance, and it is failing because of the excessive resistance that it is getting. So this is the basic premise for the classification of the different types of shock. Okay, so let us dive into hypovolemic shock. What I'm going to do here is to give you on the right here certain classical clinical features that you might have. And as I said, the reasons for hypovolemia: blood loss, can be at trauma or during surgery, fluid loss, GI losses, and plasma loss in burns. I mentioned that. So you usually have a patient, most often you see in the casualty, a patient with a road traffic accident, with multiple fractures of the long bones, probably have a degree of abdominal distension if he has had a solid organ damage in the bar, in the abdomen. Commonest is liver, and so you may probably have a right upper quadrant tenderness. Because of his loss of volume, he will have a low thready pulse. And because there is blood loss, not just loss of volume, he will more than likely to be pale. He will be hypotensive. He will be sweaty. He may be confused, and he will be over breathing. This is the classic picture of a person with a hypovolemic shock that you will encounter in the emergency department. In a cardiogenic shock, common causes I have said are myocardial infarction, CCF, and toxic myocarditis. The patient, because the commonest cause still is myocardial infarction, is likely to have chest pain and restlessness. Classically, they'll be very, very sweaty. Apart from his pump failure, you may encounter irregularities of rhythm, which will make his myocardial infarction worse. So you may expect a possible irregular pulse. The patient will be hypotensive, and because of the backup of fluid, you're likely to have crepitations in the lungs. There will always be a degree of congestion, and so not only in the lungs but also in the right heart area, and so you will have a raised JVP. These are the classic features of a cardiogenic shock. Contrasted to the hypovolemic shock, is unlike, you will have a very low JVP. There will be a very low central venous pressure. And so the pressure, you will not see prominent veins. In fact, most of the time, they are shut down so much as a compensatory mechanism that it will be difficult for you to get a peripheral access. The veins are all collapsed. So you do not get a raised JVP in a hypovolemic situation. Obstructive shock is very much like cardiogenic shock. honestly, I think it will be very difficult to differentiate between the two on clinical grounds. The classic examples here they have already mentioned will again be restless chest pain, possible irregular pulse, hypotensive, rolls. Everything is the same as in cardiogenic shock, but you will find that if you use an echo, then cardiac echo, then it is very easy to differentiate between a primary cardiogenic shock, which will show hypotensive, hypodynamic segments of the heart contrasted to cardiac tamponade. All right. Distributive shock is again classically seen in sepsis. As I said, it can occur in neurogenic situations with autonomic tone being lost. They will be hypotensive. Classically here, they will have a large pulse pressure. Okay? Even though the systolic is low, the diastolic is even lower than normal. So there will be a wide gap between the systolic and the diastolic pressure. Because of the hyperdynamic circulation, even though they're hypotensive, it is a hyperdynamic state. It's the hypotensive only because of the improper distribution. So you will find warm extremities, at least in the beginning stages. In the latter stages of septic shock, it becomes, when it's going into multi-organ failure, it will of course be, the patient will be clammed up. But generally, you'll find warm extremities, and there's a good capillary refill, again, in the initial stages. So these are the ways when you see a patient who is hypotensive in the casualty, this gives you an overview of the kind of things that you should look for and to see what kind of a shock it is. And as I mentioned, I will be focusing on hemorrhagic and septic shock because that is the commonest situations that a surgeon sees. And let us dive into hypovolemia straight away and show you some basic pathophysiology. Pawan, do you want to take this and say what I'm trying to show here?
Sir, Frank's Starling's law, if the myocardium, if it enlarges, it will pump more. That's what it's trying to tell us.
All right. Will it pump more all the time if you kept on increasing the stretch
No, sir,
of the heart?
only till
So you would expect the graph, if we kept on doing it, you would expect the graph to be going like this, right?
Yes, sir. Yes,
yeah, sir. This is the preload. Sorry, I'll let it go back. This is the preload and this is the afterload. So if you keep on increasing the preload, which means you're coming from this point, it would go on like that, but the graph goes like this. So what does it show?
Saturation.
Not saturation. Beyond a particular preload, beyond a degree of filling of the left ventricle during diastole, beyond that point, the stroke volume or the ejection, okay, the amount of volume of blood that the heart puts out becomes less. It flattens out. So when you have hypovolemia, instead of the preload being at an optimal level, which is here, a good stroke volume, the highest point is about here. Your preload or the filling will be here because there is less blood and less end diastolic volume. Okay, EDV is less. And so the body compensates for it by causing vasoconstriction. Vasoconstriction also adds to the problem beyond a point with an increased afterload. The pump has to work harder. And so what happens is that the stroke volume is reduced because of reduced end diastolic volume. And what is the degree of reduction is determined by Frank-Starling law. And it has clinical significance in that when you have a decreased preload, you don't want to fill them up to this point, all right, where there is the law of diminishing returns. You do not want a huge filling up. Whereas if you fill them up this is the point, from this point, if you fill them up to this point, then you will get the maximum output and the best results clinically. That is the importance of understanding the Frank-Starling law. Now, this is a very complicated formula. I do not want you to break your head about this, but you must understand that oxygen consumption VO2 of the tissues is what is really important. It is a function of the cardiac output, which is Q, and the oxygen content of the blood. The dissolved oxygen in the blood is extremely low. Can you tell me a mechanism where you can increase the dissolved oxygen in the blood? Can anybody tell me where you can increase the dissolved oxygen? I'm not talking about oxygen saturation. Pavan, want to guess?
Sir,
Nishant, want to
don't know.
guess? Nishant, want to have a guess?
Sir, we have another two volunteers.
Volunteers.
Kunj and Sai Ashray, sir.
Okay,
Kunj, you can try answer.
we'll give it to the students. Who is the other volunteer?
Kunjan and Ashray.
Ashray. Kunjan, have a go. You want to? How can you increase the dissolved oxygen?
By giving hyperbaric oxygen.
Excellent. That's right. That is the answer. If you have a hyperbaric system, you can increase the dissolved oxygen. We don't normally use it, but that is the mechanism. But by and large, we do not depend on dissolved oxygen in the blood. We look at the saturation. So if you increase, that is the content. Content is dependent on hemoglobin concentration and saturation. So there are you can calculate these things. I don't want you to even think about remembering these things. I do not believe in mugging up formulae. But the point I'm trying to make is oxygen delivery to the tissues, VO2, is dependent on oxygen content, and the content is dependent on hemoglobin concentration and saturation. So when you have a normal situation with normal content and normal delivery, you will have aerobic metabolism in the tissues. Both in septic shock and in hypovolemic shock, when you are hypotensive, then you will find that at one point in time, you go on to anaerobic circulation, but the tissue still survives. And at this point, you must intervene as a doctor and try to bring back the circulation to go back to the aerobic phase. If you do not manage that, even inevitably, you will end up with tissue death. And so please remember, when you have an anaerobic metabolism, that is the point where you have to work very hard to bring the patient back to aerobic metabolism. Now, if you look at the clinical stages of hypovolemic shock, remember I'm talking about hypovolemic shock here, then there are 4 stages that are recognized. This is also called a tennis score classification, because it has to do with the amount of blood loss that you have, 15%, 15 to 30, 30 to 40, and more than 40. That reflects, as you can imagine, the tennis score that we have for each of those games. And so if you have a reasonable 750 ml, 15% blood loss, there is only a very marginal, if any, increase in the heart rate. Pressure will be maintained, and the supply by and large meets the demand. If you have a 30% loss, 15 up to 1500 ml, the body compensates by an increase in the heart rate, but still it may not be able to maintain the systolic blood pressure. It will be reduced, but it will not be too bad. And to increase the oxygenation in the blood because of hypoxia with reduced circulation, there will be hyperpnea, there will be increased heart rate. And because you're shunting blood away from the kidney, you want the blood to reach the brain and the heart, there will be a degree of oliguria, and the patient will be agitated. Even here, the supply generally meets the demand, and tissue death or organ failure is unlikely. In stage 3, with a 2-liter blood loss, there will be a significant increase in the heart rate. Pressure will be significantly reduced, and similarly, there will be a severe oliguria. Patient is confused, and this is a stage where the supply does not meet the demand. And in stage 4, of course, it really is a very, very difficult situation. And if the patient reaches you in any of these stages, we have no justification as doctors to allow him to reach this stage. We must intervene so that he doesn't reach stage 4. Now, I'm going back to the so-called ABCDE of resuscitation, because this is important when you meet a patient with hypotension in the emergency department. If you know, some of the recent papers have called this ABCDE. They think breathing should be given more importance than the so-called airway, because airway blockage or airway obstruction is less common. The breathing is a bigger problem, but the classical teaching still is ABCDE, and you can also remember it better. So the first thing that you do when you see a patient with hypotension is to make sure that he is breathing. If there is any obstruction to the upper airway in the mouth or in the throat, suck him out. Seat him comfortably, or make him lie down comfortably. You need to look at the respiratory rate, chest wall movement, quickly percuss to see if he has a pneumothorax, do a auscultation and look for entry of breath sounds. Hook up a pulse oximeter, make sure that he is not hypoxic. If he is hypoxic, you've got to give him an oxygen straight away through nasal prongs or a mask. And if he's worse than that, give him a bag mask ventilation. Suspect a pneumothorax, put a needle in or put a chest drain in to decompress the tension pneumothorax. Now, for an undergraduate who has not seen many patients in the casualty, this may look very, very, very daunting. But please note that once you spend some time in the casualty, and when you see patients with hypotension, all this becomes second nature, and one can take it fairly calmly. Circulation is the next thing that you focus on. You look for pallor, you look for sweating, capillary refill time. When you pinch on the finger and see and let it go and see how quickly the capillary filling, the finger, the base of the nail becomes pink again. You look for the pulse rate, the auscultation, and of course, by definition, these people are hypotensive. Electrocardiography, you hook up a machine, but this comes definitely well after you have attended to the chest in terms of pneumothorax and breathing and restoration of the airway. If you have bleeding that is obvious, then elevate the legs, and this is very important. Also remember that when you're seeing a patient, if you have help, you must ask for help first. When somebody who's very ill comes to you in the emergency department, ask for people to come and help you. You can't do it alone. So while you're dealing with the chest and looking at auscultation, somebody else must have access to the peripheral veins straight away so that you can infuse him rapidly with saline. What to give, how to give, when to give is something we're going to talk about as we go along. If you have an obvious bleeding point, put pressure on it. And if you find that pressure does not stop the bleeding, you can put a tourniquet proximally. And whenever you use a tourniquet, always note on the tourniquet the starting time. You do not want to leave a tourniquet behind for more than half an hour at the most, because you need to have a definitive procedure to stop the bleeding within 30 to 45 minutes. All right. The D of resuscitation is disability. You look for the level of consciousness. The classic measure of consciousness is the Glasgow Coma Scale, and this is what the components of a Glasgow Coma Scale are. Is he responsive to simple command? Does he move? What are the pupillary light reflexes? And try and make sure that you get a blood glucose measured through a GRBS as soon as you can, because that's one of the things that you need to attend to. Treat the airway, breathing and circulation. And finally, please expose the patient completely. Please note that when I say final, it is not the final thing. Somebody else will be doing this for you. Some other member, maybe the third or the fourth member of the team, will be doing this for you. You've got to see the patient from top to bottom to see what the cause of his hypotension, the cause of his shock is. All right. So when you are looking at the initial resuscitation or initial assessment in a hypovolemic shock, please remember that you have made an initial assessment, you are given a fluid challenge of about half a liter as soon as you get your get your peripheral lines in. Not responding. If he's responding, then you have more time. You can then look at various other things. But if he's not responding, you have to get them to an intensive care unit. That is an important thing. You can't hold on to them in the holding area of the emergency room or in the ward. You've got to get them or at least warn them about it. Sometimes the situation can be so bad that you may have to take him to the operation theatre straight away. These are exceptions. These are exceptions. But by and large, you will be able to monitor them better in an intensive care unit. And you can also get more tests that are required in the intensive care unit. So this chart I have put up only to sensitize you to the fact that after the initial assessment, if there isn't a quick response to the patient, think seriously about either shifting them to the intensive care unit or to the operation theatre. By this time, you would have had the help of specialists to come and see the patient. This is not, as soon as you get a call, apart from taking help from the people in the emergency room, you must also send notices out to specialists, surgeons, orthopedic surgeons, plastic surgeons, and the like, and physicians if it's a cardiogenic shock, cardiologists. Send them out, send a notice out to them so that they can come and help you out in the situation. All right, and the general indication for fluid is 30 ml per kg of Ringer's lactate in the first 3 hours. If you have a 50 or 60 kg person, you can easily give 1.5 liters in the first 3 hours. You can push half a liter to 1 liter straight away. The question comes, what if the patient has cardiogenic shock and you overload the circulation? A simple answer to that is that the history, as I told you, will be different and the JVP will be very high in cardiogenic shock. If the JVP is high, you see a pumping, dilated central vein. Do not push so much, but most of the time you will find that it will be hypovolemia and there will be a flat JVP. There will be a very collapsed vein, in which case you can push anywhere from 500 to 1.5 liters or 1500 ml fairly easily. There is a question as to whether it should be Ringer's lactate or whether it should be Isolyte M. I'll tell you about it a little later. But by and large, please remember there is no role for colloids or albumin in resuscitation. Do not use a colloid. Now, the next step, as soon as you see the patient and if you do a quick once over, as I call it, see the person, you have made sure that the airway is patent, you have ruled out a pneumothorax, and if there is a pneumothorax, you put a needle into it or a catheter into it, you've got peripheral lines. The next thing that you do is to do the following tests. So can I ask somebody else to say, why are these things important? Who will be this? Pavan, go on, take a go. Pavan, are you there? Hello, somebody else? What were the other names? Ashray, is it? Ashray, you want to have a go? What is NIBP? Okay, non-invasive blood pressure monitoring. Okay, non-invasive blood pressure.
Okay, sir.
Right. Why would I want to do that?
After treating the patient to know whether the person is improving his condition or
no, I told you take a blood pressure. Now I have put a line there, NIPP, comma, with a question mark, arterial catheter. Why would I do that? All right. NIBP gives you automatic reading all the time. You must have seen it in the operation theaters. You would have seen it in ICUs. So you can't keep on pumping and taking the pressure every 2 minutes, every 3 minutes. This machine, you can set it to measure the blood pressure every 3 minutes, for example, every 5 minutes. You can set it, the duration, every 2 minutes if you want. So as you are doing the resuscitation, NIBP gives you a practically continuous recording of the blood pressure. Okay, it is practical continuous because every time it has to pump up the cuff, and it may be 2, 3, 5 minute intervals. But if the patient is really ill, you can even get an arterial catheter and hook it up to a transducer, pressure transducer, in which case it gives you a real continuous pressure. all the time it is measuring the pressure. So in very ill patients, if you find that this initial resuscitation has not brought the pressure up, it may be worthwhile using an arterial catheter and a continuous measurement of the systolic pressure through a catheter, through a transducer. An ECG has to be done. You can always have the 3-lead ECG monitor that comes on your monitor, but sometimes for more detailed information about possible ischemia and possible arrhythmia, you may have to keep doing 12-lead ECGs. At least one of them is a must. You may have to repeat it a year or two later. Why would you want a central venous pressure, CVP? Why not peripheral lines only? I told you put two cannulae, good venous access, good bore. What is a good bore peripheral cannula for you, Pavan?
Hello, sir.
Yeah. When I say, the standard, I told you when we were looking at the examination, as soon as you see this patient, get 2 cannulae of a good bore into the patient, good diameter. What is a good diameter peripheral cannula for you?
Large diameter.
What is a large diameter? What will you ask the nurse for?
14 or 16 gauge.
16 gauge, yeah. 16 gauge is a good one, a gray cannula. They're all color coded. A gray cannula is very good. Please, at least, if you find that it's difficult to get a gray cannula in a collapsed vein, at least use a green cannula. All right, which is 18. But do not use 20 or 24, 22 or 24. The pink is, I think 18 is 20, I think. Do not use the pink and the blue cannulae. They're very small, easy to get in, but they're useless. Why do I say they're useless?
Large amount of blood cannot be pumped. I mean,
correct.
fluid.
You cannot give blood at all with these small cannulae, and if you want to give crystalloids, that's what I said. Give Ringer's lactate or Isolyte M. Even that cannot be pushed in large quantities. So you must have a large bore cannula. I'm talking about CVP here. Why would I want a CVP?
To measure the right atrial.
Correct, but why do you want to measure that?
Preload.
Correct, to make sure that the preload is adequate. So it gives you a way, you see, first of all, you have a large axis, all central lines are of a large bore, so you can transfuse a lot of fluids. If you want to use inotropes, you can use inotrope through central lines quite well, because in the peripheral area, if there is extravasation, you can end up with the skin necrosis and things like that, which is a problem with inotrope. And third, you can measure the central line quite well, central pressure quite well, so that you can decide on the adequacy of filling. Now, if you find that you have given enough fluid, I told you about a bolus. So you put a central line, you're given 1.5 liters of, say, Ringer's lactate or Isolyte M. There is a transient increase in the blood pressure. The pressure is good, and then you'll find that the CVP and the blood pressure both fall. What does it indicate?
Heart failure.
No.
No.
CVP will be high in heart failure.
Yes.
Something inside the abdomen. Yeah.
Some bleeding inside the, which is not
There is
being treated
continued
yet.
blood loss. It means that there is continued blood loss. It is a classic indication for surgeon to explore the abdomen. All right. This is continued after initial resuscitation. If the patient drops his blood pressure, drops his central venous pressure, there is continued hidden blood loss. It's either into the abdominal cavity or into the GI tract. It may even be a GI blood loss, which you never see outside. But it tells you that there is something going on. And so you need to then focus on the GI tract and on the abdomen. How would you do that? How would you know whether it's bleeding into the abdomen or into the GI tract?
By doing a fast USG, like.
Excellent. You do a fast, it will tell you if there is fluid collection in the abdominal cavity. If it's not there, do an endoscopy and you will find that there will probably be bleeding there. Okay. So that is a little beyond, I went beyond this slide, but I wanted to impress upon the fact that CVP gives you a good idea about what is happening when the initial resuscitation fails. And so before it fails, you should have a CVP in place. Urinary catheter, of course, measures the blood, the urine output, saturation with pulse oximeter. In sophisticated centers, many people don't have it, but many sophisticated ICUs will have a transesophageal echo. And what are you measuring in that?
Base of
Only
heart.
theoretical. I have never done it myself, but I'm just saying, what is it that you do with a transesophageal echo? You measure the actual cardiac output. Okay, you can measure the cardiac output, which can fine tune the treatment for any kind of shock. Now, the blood markers for that you have to have straight away are listed here. Okay, these three. All right. Now, tell me, why would I ask for this?
Acidosis.
All right.
Anabolic after
Acid.
anaerobic metabolism that can lead
Excellent.
to
So we went, yeah, that's right. So we talked about aerobic and anaerobic metabolism earlier. So once you find that there is an anaerobic metabolism, then you need to measure it, and the lactate content and the base deficit being high will tell you that there's anaerobic metabolism. Serial hemoglobins are measured, at least twice a day to see if there is continued blood loss, but this is a poor indicator. Okay, please understand that more than HB, PCV is slightly better than the hemoglobin concentration itself. But even PCV is a poor indicator because it's a function of how well you resuscitate and what the fluid volume is. And so please do not completely depend on HB or PCV to decide whether there is ongoing bleeding or not, but it is some indicator that you can consider. And if you look at the ultimate result of effect of resuscitation, we told you that we need to avoid tissue hypoxia. So what should you measure? You must measure tissue oxygenation. So there are two parameters which are in the experimental stage. I just wanted to make you aware of it. It is not done in clinical practice, but muscle pressure of oxygen as well as the pH of the bladder mucosa are two things which are the most sensitive indicators, but they are as of today still experimental tools. Now, commonly evaluated fluids as to what is to be given in the initial resuscitation come under two categories: colloids and crystalloids. Now, hydroxyethyl starch, HES, gelatin, dextrons, and albumin are colloids. Let me tell you straight away, do not use it. For a postgraduate, I'm going to ask about studies and this and that as to why and what are the problems and all that. At an undergraduate level, I don't think you need to know what needs to be done. Crystalloids are the ones that you need to know about. As I said, normal saline, Ringer's, and Isolyte M are the three common crystalloids. Please remember, do not give normal saline. And there are various studies which show that normal saline can give you trouble. So use either Ringer's lactate or Isolyte M. And so this is a balanced solution. And these are the papers which tell you why you should use either of these two. Sodium near plasma levels, less chloride, it's a balanced pH, but the issues are it has a low osmolality and is probably better avoided if there is head injury. All right, because you can have an increased incidence of cerebral edema if you use Ringer's lactate. So in patients, multiple trauma with head injury, go for Isolyte M. Again, it has all the advantages: less chloride, near plasma levels, balanced pH, and balanced osmolality. So if you do not have a head injury, you can consider Ringer's lactate. But if you do have a head injury, consider using Isolyte M as your first crystalloid of choice. So I have summed up everything with this consensus. I do not want to use this, go dilate on this, but use a balanced isotonic crystalloid solution, avoid colloids, and this word accept hypotensive resuscitation is something that you need to know. Does anybody know what it is? Can you tell me? Ashray, what is the second name? Pavan, Ashray, and the third one? Kunjan, I haven't heard your voice yet, I think.
The Kunj, sir.
Kunj, have I heard your voice? Yeah, go on. Kunj, tell me. What is hypotensive resuscitation?
So basically, we'll keep the vitals towards the normal, lower normal limit.
Okay.
So that, basically the damage control surgery concept, we can use that in they like support?
Well, I think you're heading towards it. Why is it important? Why do you not want normotensive resuscitation? It is like putting water into a bucket with a hole in the bottom. Okay, you keep giving
Yes, sir.
fluids, blood from the top end, bleeding is continuing, and it's of no use. So you want the patient to be alive until you take him to the operation theater, and as you quite rightly said, do damage control surgery and stop the bleeding. So you just want to keep him alive until you stop the bleeding in the operation theater. So do not aim to have a systolic of 100 or 120. The systolic of 70 or 80 is enough. More than the systolic pressure, aim for an MAP of 60. Okay, if you have a mean arterial pressure of 60 or even a systolic of 80, it is good enough. The patient will be alive. He will not have irreversible tissue damage. Take him to the operation theater quickly, stop the bleeding, and then increase your fluid administration, either crystalloid or blood as may be required, and then bring the pressure up to 120. That is the concept of hypotensive resuscitation. Okay.
Okay, sir.
So in
Yes,
trauma, the three things you must watch out for. What kills the patient is called the lethal triad or the triad of death in trauma. It is coagulopathy, hypothermia, and acidosis. All right. We already talked about acidosis. We are measuring the base deficit. You must try and correct it. You do not correct it by giving bicarbonate. That's not the idea. Correct it by correcting the low circulatory situation. All right. And always when there is blood loss, there will be coagulopathy. There are many reasons for it. I won't go into the details of it. Hypothermia can be not only because of the ambient temperature. Of course, in the cold countries, hypothermia is very common. You may say in the tropics it is not, but in our country, even if the ambient temperature is quite warm, by giving fluids and medicines from the fridge directly during resuscitation, you can cause hypothermia. And also remember, in a very crowded small room with an AC, which may be very comfortable for the doctors who are resuscitating the patient himself may end up with hypothermia. So the air conditioning and the fluids that we administer can cause hypothermia, and that can cause increased mortality. So always have in mind, whenever you are investigating and treating a patient, think of these three things: acidosis, coagulopathy, and hypothermia. Give priority to arrest of hemorrhage, correcting coagulopathy, permissive hypotension, and another term I introduce here, permissive anemia. In a patient who does not have an underlying cardiac ischemic status, IHD, a hemoglobin of 7 is quite acceptable. So do not rush in to give a lot of blood to keep the hemoglobin above 10 or 11 just because you think the patient is bleeding. Accept a hemoglobin of 7 and a PCV of 25 as it were, and give blood transfusion only if it falls below this. The rider for this is that the patient should not be having a known IHD. In IHD patients, they do not tolerate a hemoglobin of 7. It is probably better for you to keep the hemoglobin around 10. All right. Transfusion should be given, I think, only after stopping hemorrhage. But if the hemoglobin is in the boots and you can't keep the pressure up, you can give 2 or 3 units of blood even before the patient goes to the operation theater. And when you go to the operation theater, it is, I always stress to my postgraduates, do not try to get definitive arrest of bleeding inside the abdomen straight away, because in a hypotensive patient who is bleeding, you can't do it. So when you go and open the abdomen, pack the liver and stop the bleeding. If there's a big blood vessel, clamp it. Give anesthetist half an hour to catch up with some blood. You arrested the hemorrhage. Give the anesthetist time to fill him up with some blood. If the hemoglobin is 3 or 4, then they cannot maintain the oxygenation. So give the anesthetist half an hour. Do nothing. Just stop the bleeding. Give him half an hour to catch up with the hemoglobin, and then do the definitive procedure. Because if you take half an hour or 45 minutes to stop the bleeding, by that time the patient will probably be dead. Whole blood is hardly available now. So the recommendation is to give 1:1:1 packed cells, fresh frozen plasma, and platelets. Whenever you give more than 3 units of blood, always, because of stored blood, you're using the ACD or whatever, anticoagulant, always use for every 3 units of blood, 1 ampule of 10% calcium gluconate to make up for the calcium loss. Otherwise, the patient will be hypocalcemic, and that can adversely affect your clotting. It's good to have a degree medication with an anti-fibrinol lysine. Okay, epsilon aminocaproic acid is a thing. So this is the principles of hypovolemic shock. Can we go on beyond 1 hour, or should we talk about distributive shock some other time? I took longer than I expected. So what do you want to do?
We can proceed, sir.
Okay, we can proceed. All right. I'll switch over to the distributive shock, which is the other important shock state that we see. And when we talk about distributive shock, we listed them. The commonest is sepsis. Next is the neurogenic shock with a spinal or a head injury. But let us focus on sepsis. You must be familiar with this term SIRS, systemic inflammatory response syndrome. SIRS occurs with or without sepsis, but sepsis always leads to SIRS. Okay, SIRS is a definition where any 2 of these features will be termed sepsis. So if the temperature is high, the heart rate is high, respiratory rate is high, white cell count is high, and any 2 of these, if the person is suffering from, he has SIRS. And SIRS is just one clinical situation. It's not a disease per se. And you have to define it further and understand more about it to know the natural history or the consequences of SIRS. Okay, this tells you the things that happens, particularly SIRS of the septic variety. That's what we are primarily interested in. If you have SIRS, you will find that apart from the temperature, respiratory rate and heart rate, the WBC will be very high or very low. In very, very severe sepsis, there can be a low WCC or WBC also. And because of hyperventilation, the PCO2 will be low. The patient will be hypopneic, will be washing off carbon dioxide. Sepsis is a term used for SIRS with confirmed or suspected infection. Remember, I told you SIRS can occur without infection. Ashray, can you give me 2 examples of SIRS without infection? Kunj.
They are already answering chat section also already in chat section.
All right.
Like,
But
tumors, etc.
I'm not watching the chat section, so yeah. Go on. Pavan, you have any examples? Okay, pancreatitis, head injury, burns without infection. These are classic examples where you can get SIRS without infection. So that is sepsis. SIRS because of infection is sepsis. Severe sepsis is where you have organ damage. There is no organ damage, there is only suspected or confirmed infection here. But here you have organ damage. And when there is, in addition to severe, organ damage, if you have signs of end organ damage, hypotension, and persistent, remember this is the operative word here, persistent situation where hypotension, organ damage, and high lactate continue to go on, that is septic shock. And that has untreated a mortality of about 60% and treated has a mortality of about 30%. That's a bad state to be in. All right. This is a crowded slide with a lot of pictures. I put it up to tell you only 3 simple facts. All these things are mediated through various chemicals. Chemicals are of 3 basic nature, three basic types, products of the bacterial wall and its contents, basically outer membrane protein and lipoproteins, which are their effects on the neutrophils, mast cells, and lymphocytes. You have pro-inflammatory mediators coming from the endothelial cells, TNF, tumor necrosis factor, interleukin-1, which moderate the inflammatory process cascade, and you have anti-inflammatory mediators. Basically, it is interleukin-10 and interleukin-1RA, as it is called, which have an effect on immunity. All of them put together, you will end up with increased susceptibility, increased cardiovascular effects, increased third spacing, as I call it, loss of fluid from the circulation, and adverse or affected coagulation cascade. DIC is a classic example of that. All these things are mediated in sepsis through these chemicals, and this is a point where we can talk a little bit about third spacing. Could you tell me what I mean by saying third spacing, Pavan?
Sir, any body cavities?
All right. Only body cavities or anything else?
Not sure, sir.
When
So any
Anybody else? Can you add to it?
when fluid moves from intravascular to interstitial is
Correct. That itself is third spacing. Quite right. So you find a septic patient in an ICU. Can you classically describe his body habitus to me? Where third spacing is in action. This patient is hypotensive, he's on inotropes, you're given a lot of fluids, and what do you see in him? You see it on a routine basis in an ICU patient.
edema.
Urine output is low. Sorry, you're saying something, right? Sorry?
Edema.
Edema everywhere. It is anasarca, basically. The limb will be 1.5 times its normal size. He will have ascites. He will have hydrothorax. He will have a positive balance of 5 to 6 liters. You know, you give him 5 liters and he has put out half a liter out. Positive balance of 5 liters. And so when the sepsis gets better, when you've treated him and if you're successful in the treatment, then it reverses. So what happens when it reverses? The edema goes down,
Fluid
that is
overload.
obvious. Okay. What else happens?
Fluid overload.
Overload doesn't happen. The body manages to get rid of it. The urine output increases. Okay. In a septic patient, when you start with, you give them 4 or 5 liters of fluids, inotropes, pressure is not maintained, urine output is low. He swells up, within the next day, within 24 hours, he'll be positive by 3 kilos. If you measure his weight, by the end of treatment, a septic patient could have put on 10 kilos in weight. All of it is body water, third spacing. Okay, 10 kilos, it's not a small amount. So when they get better, the first thing that happens is that the urine output increases. The first sign that happens, you will need less and less inotropes, and the edema goes down. That means you have won your battle against sepsis. That's an important point to remember. So investigations wise, when you have a septic patient, you have all these conditions that we talk about, and you've got to do these things. Let me say here that I have shared this presentation with Kishan and Nishan, so they can share it with you all the time. So you don't have to worry about taking notes and things like that if you're doing it. I should have said this in the beginning of the talk itself. Anyway, you need to do these investigations. Complete blood count, random blood sugar, creatinine, urea also, but I think creatinine is always more useful than urea. Liver function tests, amylase and lipase, coagulation profile, D-dimer, platelet count to look at the coagulation cascade, serum lactate, blood gases to look at base deficit, as I said, an ECG and echo to look at the cardiac status, a chest x-ray, an abdominal ultrasound. It may well be a fast, it may well be a focused abdominal ultrasound, okay? Urine and blood culture to look at possible infections. And if time and condition permits, and if you do not have the necessary information from any of these investigations, you must consider a CT chest and abdomen. These are the common investigations that you do for a patient who is suspected to be in septic shock. Now, the treatment of septic shock has been made formal and has been sort of regimented since the last decade or so. And since 2012, there has been a big campaign called the Surviving Sepsis campaign. They in fact have a website, and those of you interested can go and look at the website, and a lot of information from there is available free. And they talk about bundles. They talk about the 1 hour bundle, they talk about the 3 hour bundle, and they talk about the 6 hour bundle as to what is to be done to a patient who comes with a suspected, remember you don't have evidence yet, but a suspected septic shock. Suspicion can be high on various situations. If you have a patient who has had an anastomosis and comes to you a week later with hypotension, you might even have sent him home, but he comes back a week later with hypotension. The first thing you think of is possible sepsis, either in the urinary tract or an anastomotic leak or in the chest. So septic shock can be suspected on clinical grounds, and when there is that situation, you use these bundles. Please remember, these are practical steps which have to be carried out and quite easy to remember as well. Apart from all the tests that I mentioned, which you may not remember in one go, you will remember those once you have looked after a few of these patients. For a septic patient, measure the lactate level, obtain blood cultures before you start any antibiotics, administer a broad spectrum antibiotic. I usually always say what is to be used. For a surgeon, it has to be both gram-positive, gram-negative, and anaerobic organisms to be fought. And my favorite is piperacillin, tazobactam, and metronidazole. You can use other third or fourth generation cephalosporins like ceftriaxone and metronidazole. You can use clindamycin instead of metronidazole, but it has to be a broad spectrum antibiotic. Begin rapid administration. As I told you about earlier, 30 ml per kg of a crystalloid. As I told you, Ringer's lactate or Isolyte M, about a liter. And this has to be within the first hour. And as you're giving it, as you're building up the intravascular volume, remember, even in a septic shock, distributive shock, intravascular volume is low. So they are relatively hypovolemic, even though there is no fluid loss. So you have to make up that fluid, bring the CVP up. I'll tell you in the next slide what it should be. Use vasopressors, and I'll tell you what vasopressors have to be used. You have to remeasure the lactate if it is already high, perhaps every 4 to 6 hours to see how you're faring. 2 millimoles translates to about 18 milligrams per 100 ml. We measure it in milligrams. So the 3 hour bundle is no different from the 1 hour bundle. I wonder why they kept it, but I think the SSC, the Surviving Sepsis campaign, kept it there perhaps to reiterate that these things have to be completed by 3 hours. If it is not already completed by 1 hour, completing this by 1 hour is definitely any day preferable. And to be completed in 6 hours are these. You have already applied the vasopressors. Remember, keep the MAP around 60 or 65. In the event of persistent hypotension and initial high lactate, CVP has to be measured. So I think by the end of 1 hour, if the patient is not stable, you must have a CVP. And this is the real extra recommendation, the Swan-Ganz catheter. I must say that practically we are not doing it. Swan-Ganz, or the central, the balloon flotation catheter, is the one that measures your central venous oxygen saturation in the pulmonary artery. That is the output of the right ventricle. But there are so many other problems with the Swan-Ganz catheter that I think if you measure the central venous oxygen concentration at the SVC, it should be enough. And so don't necessarily go for a Swan-Ganz catheter. When I was training, for example, 30 years ago, it was a routine for us to float Swan-Ganz catheters. Now, because of its downsides, we have stopped doing this. And you must remeasure the lactate if the initial level is elevated, perhaps 6 or 12 hours later. But what is important is to understand this. the target is very important. The CVP must be more than 8. This is the commonest. You must give enough fluids to make sure that the CVP is more than 8 to 10 millimeters of mercury. The central venous oxygen concentration must be more than 70. If it is less than 70, it means that there is still a lack of circulation and the oxygen is being extracted by the tissues a lot more than normal, which means that there is a lot more demand for oxygen than supply. That results in a low SCVO2 and normalization of lactate. These are the 3 measures that you employ to make sure that your resuscitation is adequate. Okay, Kishan, if there are any questions, please keep a note, because I'm not looking at the chat section. Okay.
Yes.
So I mentioned about using the vaso. Sorry. Yeah, I will take the questions.
I am following the question, sir.
All right, I'll take it at the end of the talk. Yeah, I told you about administering vasopressors. I do not think I want to give you all the details of this, because at the undergraduate level, it is certainly not necessary. Postgraduates must know this, because they will be looking after these patients in the ICU, taking responsibility for their care. But please remember that if the systolic pressure has fallen below 30 millimeters of mercury, or the MAP is below 60 millimeters of mercury, mean arterial pressure, use a vasopressor. Okay, the SSC recommendation is very clear. Noradrenaline is the drug of choice. Noradrenaline is the drug of choice. If one vasopressor does not bring up the pressure or the MAP, use another one straight away, soon afterwards, which is half to 1 hour after you have started the initial vasopressor, and it should be either vasopressin or adrenaline. Okay, either vasopressin or adrenaline. Half to 1 hour after the initial vasopressor, if the pressure doesn't come up, please add another pressor. Should you have 3 or 4 vasopressors? The answer is no. Beyond 2, it is very, very unlikely to help you, even though in the ICUs, we see a lot of those. But for a surgeon, as we said, in a hemorrhagic shock, the surgeon may have to take the patient to a theater straight away from the emergency room to stop the bleeding. All right? Exactly like that. In a septic shock, he may have to take the patient to the theater to attain what is called source control. Unless you clear the source of sepsis, it may not be mechanically possible for a surgeon. If it's a UTI or a pneumonia, you can't clear it. But if it is an abdominal abscess, if it is a soft tissue infection, as I have shown here, if it's a perianal infection, infected catheters can be changed. And of course, UTI and chest infection has to be treated by the appropriate antibiotic. This is a classic case we did recently. This patient had a perianal abscess, and that infection had spread across here onto the abdominal wall. And to prevent him from going into septic shock, he was definitely septic. He had SIRS plus infection, but he wasn't really hypotensive. But we kept him in hospital, covered him with antibiotics. But just that was not enough. We took him to the theater and cleared the abdominal abscess as well. You can see the corrugated drains here where we have drained the abdominal abscess. So a vigorous source control is something which you must always think of as a surgeon in a septic patient. Just one word about cardiogenic shock. I'm not an expert, I'm not a cardiologist, but please understand that cardiogenic shock has this natural history. The mean arterial pressure keeps coming down because of the pump failure. The SVR, systemic vascular resistance, keeps going up. It keeps going up all the time. And once that compensatory mechanism kicks in, you may have a little increase in the pressure. But if it continues to happen, then the pump cannot manage anymore. And so you will have a fall in the BP, and it reaches such a stage that the patient dies because even the SVR mechanism fails. So this is the irreversible mod stage here. So you got to keep them, catch them at end organ failure state. And the mechanical, there are various methods which I'm going to mention only. The mechanical apparatus that we use, machines that we use, which is the IABP intraarterial balloon pump, and the left ventricular assist device. Those are the things that can happen only in the early stage. If you try to give it at this stage where the SVR is trying to come down, these machines will not have any effect. So remember the golden hour, just like in trauma and head injury, you also have a golden hour in cardiogenic shock. It is a situation with a high mortality, and these are some of the things which you may remember. I'm not going to details. Noradrenaline is the vasopressor of choice. Do not use dopamine or epinephrine. Early vascularization is practiced. If somebody has a myocardial infarction, an early stent will help them. Mechanical support devices, the one I mentioned about, this is a picture of a left ventricular assist device. It is always better, considered better than an IABP. You can also use extracorporeal membrane oxygenator. Okay, that's another assist device that you can use to treat cardiogenic shock. Okay, this is a summary of the kind of vasopressors that you use in the ICU. I told you for septic shock, you use noradrenaline, and you can add vasopressin and adrenaline if you require. Cardiogenic shock, use norepinephrine, if necessary, dobutamine. Do not use dopamine and adrenaline. Anaphylactic shock, drug of choice is adrenaline. Neurogenic and anesthesia-induced hypotension, phenylephrine. Phenylephrine is the drug of choice. So these are the things that nobody will ask you at an undergraduate level, but I presume there are a few postgraduates here. So I thought that it would be nice to know that there are quite a few vasopressors, and it's important for you to know which you use first in an ICU. So to conclude, shock is a life-threatening phenomenon. We should be aware of how to assess it, how to take the initial steps, and how to progress with it depending on what kind of shock it is. Naturally, these things require understanding the basic diagnostic steps in resuscitation. You must be aware of what monitoring to use and what principles, what fluid to use, and the vasopressor administration. I hope what I have said has made some sense to you. And finally, for a surgeon in septic shock, like he is required to stop the bleeding in a hemorrhagic shock, in septic shock, he is required to get source control. This is the CT of a patient with a subhepatic collection after an infected collection after a lap chole. Okay, this is a patient who ended up with a percutaneous, he became septic, and we treated him with percutaneous drainage of this subhepatic abscess, and he got better. Thank you very much, and I'm ready to take some questions if you have any.
Sir, what is the role of pressors after initial stabilization in a hypovolemic shock? Is there any role of pressors?
You don't need it at all. You don't need it at all. Initially, as you're filling the patient up, you may, as again, to keep the MAP above 60, you can use noradrenaline and keep the pressure up, keep it around 80. And once you stop the blood loss, or once you make up for the lost fluid and get the CVP up, you can taper your pressors very rapidly.
So I have a doubt.
If you use the vasopressor, yeah, go on.
Yeah. So what is the cause of agitation in stage 2 of hypovolemic shock? Like, why is the patient agitated in that condition? Any specific reason?
Cerebral hypoxia. In spite, see, cerebral circulation is the best auto-regulated circulation in the body.
Yes, sir.
In spite of systemic hypotension, the cerebral circulation will be the last one to go. But even if the circulation is adequate, the patient is hypoxic. If you measure the saturation, oxygen saturation in these patients in shock, they'll be hypoxic. And so cerebral hypoxia is the cause of agitation. And if it becomes so bad that even the cerebral auto circulation is affected, then they'll go to coma. Initial agitation, later coma.
Okay, sir. And so one more doubt, like
That
why
is
don't
the-
we use dopamine in cardiogenic shock? Like it promotes renal diuresis. So why can't we use dopamine in cardiogenic shock?
Yeah, that's a good question. It has so many other effects other than just renal circulation.
Like depending on the concentration in the blood, there are different mechanisms. So like
quite right. So if you saw my list, dopamine didn't figure in it at all.
Yes, sir.
You understand?
That's
Dopamine was used by us, for example, when I was in my initial stages of my training and my practice, dopamine was the commonest vasopressor that was used. But now it has been shown that many studies have shown that their overall side effects, particularly the oxygen demand of the heart, all right?
Yes, sir.
It increases the oxygen demand of the heart, and in a cardiogenic shock, already there is less oxygen for the heart. So if you increase the oxygen demand, they fare worse. That's why it's not recommended.
Okay, sir. Yes, thank you, sir.
Sir, is there a role of steroids in case of septic shock?
Good, very good question. I didn't mention it because it's a very controversial subject. Steroids, as used in therapeutic doses, we used to give them 1 gram of methylprednisolone, is completely out of the window. And the present recommendation is that you do not give steroids unless you expect a hyper added or super added hypoadrenalism. Please understand that sepsis can destroy adrenals. Previous steroid administration or hypopituitarism are all conditions which can suppress the adrenal. In these states, if the patient becomes septic, you have to give them only therapeutic doses of steroid administration, which means not big doses. Give them 100 hydrocortisone, maximum 100 to 200 milligrams of hydrocortisone 3 times a day IV. That is all that is required. And that too used with great caution because it has no real salutary or advantage in septic shock. Nishant, you want to add something? I think you wrote a little paper on that.
Yes, sir. What they said is the indication is only in refractory shock, that even after using vasopressors, if there is no improvement, only as a last resort, you're going to use steroids. Otherwise, they can worsen the
small
sepsis
doses,
itself.
not in big doses that we used to do.
So one more question was,
sorry?
One more doubt was, won't vasopressors increase the afterload and decrease cardiac output?
It's all a question of relativity. If the afterload is becoming very high, then it will definitely reduce the stroke volume. It will put a bigger strain on the heart. So the kind of vasopressors that we have recommended, the kind of dosages that we have recommended, it is shown in various studies that they have a positive effect and not a negative effect.
That's all, sir. Kishan, any more doubts?
No. Members, any more doubts, please ask. So, good opportunity for you all to clarify all your doubts for the mentors. Doubt.
I will stop sharing the slide. Yeah.
Yes, sir.
So that I can see the chat. When I'm giving the presentation, I can't see the chat. Yeah. Okay, if there are no more questions, then we will. Can we end the meeting, Kishan, Nishant?
Yes, sir. We have cleared most of the doubts. So.
Okay. Either they have understood everything or they have been overwhelmed. One of the two. What is it?
Understood, sir.
Okay.
Yes, I understood.
Okay. Thank you. All right, folks. Then.
Yes.
I'll leave you and thank you for this opportunity. And you're always welcome to ask me if you need anything at all. Okay. Thank you very much. Bye-bye.
Thank you, sir.
Thank you, sir. Bye, sir.
Thank you, sir.